Hello, everyone. Welcome to Iowa Ideas. My name is Aaron Murphy. I am the Des Moines Bureau Chief for the Gazette, and this session is called Building the New Structure for Behavioral Health Care. And we are coming to you this morning from the Human and Social Services track in this year's Iowa Ideas Conference. So, as a quick background here, in early 2024, the Iowa legislature passed a bill to unify mental health and substance abuse treatment programs in the state by disbanding and redefining service areas for behavioral health care. This session will review the new system in comparison to previous attempts at restructuring, as well as the possible benefits, challenges, and impact. And speaking of their social services track, we have a sponsor for that one, and that's Tanager. So we appreciate their support in helping us put on this event, and more on them later. Before we jump into things, before we introduce my panelists, just a quick couple of housekeeping reminders. Sessions are being recorded and closed captioning access is available. And also, for those of you listening, questions can be submitted through the Q&A function, and we'll get to those as time allows. So as the discussion goes on, if you think of a question that I haven't asked that you'd like to hear about, put that in the chat, and we'll try to get to those. All right, now that that's taken care of, let's meet our expert panelists. I'll make a brief introduction here of each, and then after I've done that, we'll hear more from each of them, kind of about who they are and what they do. So with us is Teresa Armstrong, who is with the Iowa Department of Health and Human Services. We have Leslie Carpenter, who is co-founder of and an advocate and lobbyist for Iowa Mental Health Advocacy, which is an organization that seeks to change how our federal, state, and local governments provide services and support for those with serious brain illnesses. And we have Jess Kelly, who is Vice President of Operations for Tanager, Cedar Rapids Human Service Agency that offers programs that focus on prevention, treatment, and outreach, and serve more than 4,000 children, teens, and young adults each year. So thank you all for joining us today. We very much appreciate you being here. All right. So now that I've introduced everybody, let's learn a little bit about each one of them and why they're here specifically to be a part of this discussion. So let's go around the horn here, and I'll invite each of you to tell us more about yourself, about your organization, and how that organization's work is relevant to this morning's discussion. And Teresa with HHS, let's start with you.
Great. Thanks, Aaron. Good morning, everyone. As Aaron said, my name is Teresa Armstrong, and I am with the Iowa Department of Health and Human Services. And I'm in our Behavioral Health Division and the Director of Operations and Compliance. I started with the DHS Division of Mental Health and Disability Services about 14 years ago. I'll tell I'm older. I've done a lot of other stuff, but key to this conversation is when I started about 14 years ago was at the time that the legislature was considering how do we redesign this mental health and disability services system, and we went from a county-based system to which has resulted in our current MHDS regional system. Great improvements over that 14 to 15 years of moving from the county-based to the regional system, but we still had an inability to have an integrated behavioral health system. We weren't seeing the children's behavioral health system developing in a way that we were creating access for youth. So there was just still a lot of improvements that we needed to see in the system. And with the alignment of the departments of public health, departments of human services, departments on aging, and the other kind of state departments that came to form health and human services, really gave kind of that opportunity to take a look at how our systems, how our behavioral health related systems were integrated and operating together, and is given us the really ability to take a strong look at the new way of operating and doing business, really focused on prevention, education, treatment, recovery of mental illness and addictive disorders. And I'll define addictive disorders as substance use disorder, gambling, and tobacco. So health and human service is kind of the role and in the discussion today. And our responsibility is we do have a responsibility for the implementation of this new behavioral health system, new way of operating and kind of managing the system that will hopefully get us to greater outcomes and creation of those really integrated services that we need to see good outcomes for all ages of Iowans. So we got this greater responsibility of the program and policy development, funding and resource allocation and strong oversight of not just the system, but of the administrative service organizations that are going to be managing the districts, certification of providers, development of workforce, really kind of data collection and reporting. We're really laying out the policies and the procedures and the administrative rules so that we're not creating burden on providers and that we're able to get kind of quicker and better access for people being able to navigate through the system. And kind of I said resource allocation. So how we look at how do we maximize federal dollars that can come into the state, be it through our division or broader into the system? How do we maximize Medicaid programs and to really make a truly integrated behavioral health system?
Very good. Excellent, Teresa. And something you said in there reminds me that this is a kind of another reminder for folks tuning in. This transition, this new system is in process. It's not implemented yet. The full implementation is scheduled for, and forgive me, I should have written this down. I think it's July 1st next year, 2025. Is that right?
Correct.
Okay, there you go. So this all part of this discussion is a sort. We're in a transitional phase looking ahead to next year. Okay, thank you for that, Teresa. Leslie, tell us a little about yourself and your group.
Good morning. So I'm Leslie Carpenter, and for this purpose today, I'm a volunteer advocate who came to this work because our family has two adult children, one of whom lives with a very severe schizoaffective disorder. We spend our time doing advocacy at multiple different levels, working to reduce treatment barriers for people with the most severe brain illnesses. Happy to be here for this discussion. Excited about this change and hopeful. Families like mine live in hope. Hopeful that it will be a positive transition for everyone and that it especially will improve the access for people that have the most severe illnesses in our state.
All right, excellent. Thank you very much, Leslie. And finally, Jess Kelly, tell us a little about yourself and Tanager.
Yes, thank you. So Jess Kelly, current Vice President of Operations here at Tanager. Prior to that, I was our Director of Quality. And really kind of my focus here is more on, facilitating that system change, improving care here in the state of Iowa, addressing those gaps in services, and really just how can we enhance the overall quality. We here at Tanager, as you mentioned, we do serve more than 4,000 children, teens, and young adults every year. We do that through a multifaceted approach, whether it be prevention, treatment, or outreach. We do kind of center on that philosophy that better care does produce better outcomes. And so really excited to see kind of what change we can bring here to the state, new services that may be offered, how we can streamline that, and really just ensure that there's equitable access to care, no matter where you live across our state. So really excited to be part of this today and to learn more as well as all of you with where we're headed here in the state.
All right, awesome. So now that we have a good feel for everybody and where they're coming from in this discussion, before we get too granular here, I thought maybe a little history and scene setting is in order. And Teresa, you're probably best equipped to start with that. And I think I heard, the question I'm going to ask, I already heard a little bit of the answer in your introduction there, but maybe just to have you expand on a little more. You mentioned the 2013 redesign into a regional system, and now here we are again in 2024 with another similar redesign. Tell us a little bit about how the state's mental health and substance abuse treatment systems are being changed by this new law and why HHS advocated for those changes.
Sure. So as Health and Human Services came together as an agency, we're still coming together, right? It's a whole journey and a process. But as we came together, one of the things that the director really wanted to look at is, gosh, now it's time to look at our service delivery system. So there was a lot of feedback. There was a contractor that came in and really did an assessment of all these service delivery systems that now are a part of Health and Human Services. And
Teresa, I apologize for interrupting, but it makes me realize there's some background too that I maybe should have filled in for folks who don't eat, sleep, and drink this stuff every day like we do. You're talking about the recent reorganization of state government and the executive branch and state agencies,
Correct.
a streamlining of myriad state agencies. And one of the biggest parts of that was it actually kicked it off before the rest of them got into it, was
Right.
the combination of former health and human services with public health and a few other agencies. And that's what you're
Correct.
talking about there. I just wanted to fill
Correct.
in folks who may not know.
Yes. Yes.
Forgive me for interrupting. Go ahead.
Yes. No, no problem. Thank you, Aaron, for bringing that detail in.
Yep.
So with that combination of really merging the agencies, and as we sought really lots of kind of broad, stakeholder feedback, across the state, it became really evident with the feedback that we got that our system navigation is difficult, it's confusing, services and access are just very inconsistent, and the outcomes are not satisfactory. They're not what we want for people, and we've created a lot of probably unnecessary administrative red tape and kind of duplication of effort for the provider community. So in that, the legislation that has come together to really take a look at how do we change the behavioral health system, it really empowers the agency to work alongside system stakeholders, empowers it, expects it. It really is a model of shared responsibility of HHS having the responsibility for a behavioral health state system, but it lays the foundation for that new system to be shared, working with kind of local, kind of feet on the ground and local stakeholders. The system should be well coordinated with clear access points. Iowans should have access to services and supports no matter where they live. We should be reducing system redundancies by linking kind of our federal, state, and local governance and authority, eliminating some of the red tape and administrative burden on individuals seeking services as well as providers, putting our funding to measurable outcomes and targeting funding to where there are needs in the community and gaps, and really developing a transparent kind of a reporting system. So to achieve this, what has changed? Right now at this moment, we have 11 mental health and disability services regions. They will end on June 30th, 2025, as we move into the new system on July 1st of 2025. We currently have 19 substance use service areas. Many people know them as called as the Integrated Provider Network. Those services are not going to stop, right? Those providers will still be there providing the services, but those service areas and kind of moving the dollars out and the funding that will end. And we have 37 tobacco community partnerships that are doing prevention work areas in the state, doing prevention work related to tobacco. Those areas will end, and we're merging all of those into behavioral health districts. So we'll have local districts that will organize and have administration and service delivery at the local level. And all of the districts are going to be required to really have a wide array of local functions focused on prevention, early intervention, treatment, recovery, support, and crisis care.
All right, very good. So that's what's taken place. Leslie and Jess, I'm interested in hearing now. Your organizations are on the ground level here, providing services to folks who are served by this system. So Jess, I want to hear from each of you, but Jess, we'll start with you. These changes that are being implemented, being phased in, how will that impact the work your organization does?
Yeah, so certainly I think right now, we provide services to multiple counties across the state, primarily here in the East Central region. But when we do get individuals that live maybe outside that area, it is a little bit of a barrier to access services because every region does things a little bit differently. And to Teresa's point there about some of that kind of red tape and the administrative burden, it can be a little bit cumbersome for providers just because everyone does things a little bit differently. And not only do they do things differently, but there's different services available. So just helping to kind of navigate through that and identify what services are available and provide those linkages. So really kind of excited to see what this will bring and if there will be kind of some streamline, but also just to to reduce that because there's so many barriers in the way to access the services that individuals need. So really making sure that we're getting them what they need when they need it.
And Leslie, how about you?
So I really focus most of my work on systems advocacy and education, but I get reached out to by families, patients, doctors, lawyers looking to try to figure out services or placements, often finding a bed for somebody in acute need. So one of the things I'm most excited about is that within the RFP, in my reading of it and understanding and asking questions about it, is they're going to have an emphasis on each ASO having system navigators who intimately understand the services. And that would be really helpful because it'd be helpful to be able to, if somebody calls me from Northwest Iowa, to be able to reach out to that ASO for that area and find the person that's going to most be able to help problem solve, to help get somebody the services that they need. So from my perspective, I'm really hoping for that because there's a lot of hours spent searching and begging and coercing to try to get people care.
And that,
honestly.
Yeah, and that's a perfect transition to what I wanted to ask about next, which is those ASOs. That's one major item still on the to-do list as part of this transition and this latest restructure, is the state's selection of these administrative service organizations, again, which you've been heard to refer to as ASOs. And those organizations will work with the HHS to coordinate and oversee the services in each behavioral district. And they are due to be selected by the end of this year. Teresa, maybe could you just give us a little update on how that's going? Give us a little sense of what HHS's goal is in selecting these ASOs, and what, again, what kind of maybe fill in a little more detail on what the expectations of these organizations will be.
Sure. So we definitely had some hard timelines for the legislation. So there was some, as you said, by the end of this year, so by December 31st, 2024, we will be announcing and designating those administrative service organizations that will be the lead entities for the behavioral health districts. We also had to publish a map, make some final decisions on a map of what are our districts. So that happened over the summer. There will be 7 behavioral health districts that will be managed by the administrative service organizations. The process that we chose to use to designate the administrative service organizations was to do requests for proposals. So as Leslie mentioned, we right now have an RFP that is live and active. It was released on September 3rd, open to the public for anybody to be able to go in and view, and that starts to set the stage of what we're wanting in administrative service organizations and what we start to expect for them to do. So those behavioral health administrative service organizations are district lead entities. They'll serve as a connection point between Iowa Health and Human Services and kind of that local assessment of need and resource planning and really the direct connection for prevention services. That means they're going to have that connection and collaboration with, be it local law enforcement, educators, advocates within the system, the providers within the system, and they're going to have advisory councils. And those advisory councils are going to be made up of individuals representing all of those other service systems and those that use the services, those that need the services, kind of providing that sort of guidance and information back on what is happening. So we expect the administrative service organizations, I guess, in this large sense, to be the connectors back to feed Health and Human Services information on what we need to do to make the system better. They'll be the connectors, as Leslie said, as navigation to help people have access to those services that they need at the time that they need them.
Yeah, and Leslie, maybe come back to you first, because I'm curious, and you already started to touch on this a little bit, I think. What are your hopes and maybe even needs from these ASOs once they're selected to for your organization to be able to do its work well? What are you hoping to see from these ASOs?
Sure. So, in addition to the system navigation, I'm really hoping for them to have good, strong support for programs for people having their first psychosis, so first episode psychosis programs, because the earlier we can intervene and the more consistently we can intervene, the better outcomes we're going to get for those souls. And right now, we don't have enough of those across the state. One of the big barriers that a lot of people don't know about people that have SMI is that a lot of them have no idea they're sick. They have this condition called anosognosia, where the brain illness causes changes in their brain, so they are unable to volunteer for treatment. And one of the solutions for that is a program that we started in Johnson County called an Assisted Outpatient, or AOT program, that's highly effective for utilizing an outpatient civil commitment order, working in collaboration with providers to keep people engaged in treatment, and just as importantly, keep the providers engaged with the patient in treatment. And it's highly effective. So I'm really hoping, one of my goals for the state is to have many more than one program. I'd like to have 99 of those programs, since we have 99 counties. So from my perspective, advocating for the people with the most severe illnesses, those are two parts that I'm hoping they'll be supportive of, as well as long-term supportive permanent housing.
Very good. And Jess, how about it, Tanager? What are you watching for in this process of the selection of these ASOs?
Yeah, I think part of it is just the ease of access for care, making sure that it's readily available. To Leslie's point, not even when they get to that point where they don't know that they're ill, but it can be very overwhelming, the process, especially for those that are in crises too. So just making sure that it is easy to access and that there are individuals there and supports to help move them through, to identify what resources are available, because oftentimes us as providers, we only know what we know. So just something that identifies really what's going to be out there in every region, so we can help provide those linkages too, and the ongoing support as providers, so we know what's been offered and have that ongoing collaboration.
All right. Very good. I appreciate it. Just wanted to remind everybody, first of all, thank you for joining us, and remind everybody that if you have any questions, feel free to submit them in the chat, and those will get passed along to us, and we'll get to those as time allows. And I mentioned that because we have one, and maybe we'll break in here really quick and try to address this. And as I've read this, this one's a little bit above my pay grade, so I apologize as I read through it, and I'll toss it out to the group and whoever feels equipped to tackle this one. But this is one of those questions that when I get it, when I'm usually working on a story, I need to do about 15 minutes of research so I can understand it, and then I don't have that luxury here during the live session. So but the question is, mental health parity draft rules were released, and they placed autism within provisions for ERISA, and forgive me, that's an acronym, ERISA covered plans. Many folks here in Iowa are under the state of Iowa's plan, which is not ERISA covered. Unless the Affordable Care Act provisions are triggered, Iowa domiciled health insurers will not have to provide such parity. How can the state create that parity for non-ERISA covered plans? And then it notes that ABA therapy is just one piece. Is there anyone who feels comfortable addressing that question?
Health and Human Services does have a program called the Autism Support Program that was really developed before there was some of the insurance mandates that came about. And as the insurance mandates have come about, we've even noticed in the Autism Support Program, we started funding ABA services for fewer youth, but there still became this sort of it became too expensive for folks. It may have been in their insurance plan, so we couldn't cover it at the state level, but yet it was too expensive because of copays and all those sorts of things. So there has continued to be some gaps. One thing in this, I talk about MHDS regions, which I haven't said yet, is the disability part of services that the regions have been funding and managing. That responsibility has moved to our Aging and Disability Services Division. And one of the things that the Aging and Disability Services Division is looking at, how do we continue to have a system, and how do we have a better system that addresses individuals with disabilities, and not just like more of a narrower group, but a larger group of individuals, kids and adults. Our system was only adults that MHDS did. So they have also released disability access points, an RFP for disability access points, and we'll be looking at how do we build a system that is supporting all ages and multiple disabilities kind of across the system. So, and autism, I was saying this, autism is one of those things that is in there that they are currently looking at. As I said, right now, we do have an autism support program that does help with some of the challenges where insurance is not able to cover those services.
There you go. All right. Thank you very much for that, Teresa. Uh, One thing I wanted to ask about an ongoing challenge in this space, broadly speaking, is the Iowans who need long-term and or acute care. So Leslie and Jess, let me put this to you. Jess, we'll start with you this time. How common is that for you to see those really intense types of needs, and what are the challenges there? And I guess I should add, as we talk about this current redesign, is there anything in there that you are hopeful can help with that?
Yes, I can speak to that. I think in regards to residential services, we do provide an array of services for youth. We have a program for individuals with intellectual disabilities, as well as those with some psychiatric medical needs, and then crisis services. There's really not a lot of beds. So when we talk about our individuals with lower functioning, we're capped at a certain number of beds, and we're one of, I think, 2 providers in the state that provide services to youth. So as you can imagine, there's quite a lengthy wait for those services. When it comes to the acuity needs for individuals that do require residential care, we're finding that youth are coming in with more intense needs than they have before. And then the authorization process has been a bit cumbersome, depending on, again, what insurance provider or what MCO, if they are state funded. In regards to the hospital level, there's very few inpatient beds. So there's been a mass reduction in beds over the years. And so Iowans that do require that level of care oftentimes are sitting in inappropriate placement options, just because we don't have the support across the state that is needed. So I do know that part of this work is really to try to increase those beds or identify additional levels of care and try to get more. The crisis unit that we have now here at Tanager, that was just added this spring. So that's a new service for this area. So we are excited to see more of those opportunities kind of open across the state. But I think there is certainly work that we can do as providers and at the state level that I know is ongoing.
Very good. Leslie, same question for you on these long-term and acute care needs.
Yeah. We are massively underbedded in the state of Iowa. We're ranked 51st in the country in terms of our number of beds per people. We only have 2 per 100,000 people. We only have 32 state level child beds and 64 adult beds. And that is a big piece. It took 14 years until my son was finally able to get to the state hospital, and he received excellent, comprehensive, multidisciplinary care that he would have benefited from 14 years prior. It's a huge problem. And I know the political climate is difficult because of the closing of Glenwood and the pressures from the DOJ and the pressure to move everybody into the community. However, the reality is that we are ending up with a lot of people who end up homeless, incarcerated, or dead because we lack those state beds and also acute care hospital beds. And they're all tied. If somebody really needs a placement when they've been in an acute care hospitalization, some of our hospitals, like right here in Iowa City, the U of I, has people that they've had in the inpatient psychiatric unit for over a year because there's no place for them to go for longer term residential treatment. And that blocks the bed for somebody who's newly suicidal and in crisis from being able to get into an acute care bed. So the whole continuum has clogs in the system, and most of it is tied to this lack of long-term residential treatment and the lack of state hospital beds, which is the only place people can receive the extended comprehensive care that they really need when they have the most severe illnesses. So we definitely need to build out the intensive residential service home beds. We were supposed to have 120 of those beds a couple of years ago. I don't know the exact number of them now, but I believe it's around 50. We're still in dire need of those. But we need other options as well. And I'll say it one more time, we need more state hospital beds desperately. They're very different types of facilities than the Glenwood Center was. And the need for this is intensive. It's dramatic, and we're losing Iowans every day because we don't have those beds.
Leslie, if you don't mind my asking, and I'm sorry, Teresa. And Leslie alluded to this a little bit. There's also a discussion here about community placement and community-based care here. What from HHS's perspective, does HHS agree that Iowa needs more beds, or where is HHS on that?
Well, HHS definitely agrees with we need the right beds with the right services happening in those beds, because we have a lot of beds that do different things, but our beds aren't doing the right things. So if it's done privately, if it's done by the state, we definitely agree that we need those more intense services, and we need them available when people need them. So.
Okay. And is there anything in this redesign, this current transition that might help address that, or is that a separate kind of issue?
I think it's all tied in together. The redesign is kind of a journey and a process of getting there. Yeah, there is looking at what are the types of services. Some of them are community-based services too. We need to get to people earlier. We need, as Leslie has been saying, we need to get to people earlier. Maybe they won't need a bed. We need to get people out of the hospital into long-term care services that include their community services right along, having that more intense sort of residential care. So yes, that is part of, having the way we're going to administer the system, and we're going to be looking at outcomes for people and targeting those areas more closely where we're not achieving the outcomes.
All right, and Teresa, let me stay with you on this next question. When the redesign bill was signed into law, HHS Director Kelly Garcia said that HHS is considering building out a pipeline for providers and brick and mortar spaces to handle complex behavioral health needs, including launching certified community behavioral health clinics. I was hoping you could expand on that a little bit.
Sure. So to explain certified community behavioral health clinics, that is one of the of those services of trying to get to people earlier and offering community-based outpatient kind of integrated care. So it is, we are launching them. We are ready to go with our kind of first round of providers to line up with the behavioral health alignment on 7/1/25. But what these providers are, the bricks and mortars, they provide outpatient mental health services to anyone who walks through their door, regardless of their age, their diagnosis, or their ability to pay, their insurance status. They provide service to those with the most serious mental illness and serious emotional disturbance and significant substance use disorder, and not just the individual person, but the whole person, as well as their family, and addressing other community needs and education. Iowa was awarded a Medicaid demonstration project. What that means for Iowa is that we get additional Medicaid dollars to be able to do this and to be able to implement this. And our intent is that we will have providers across the state as we move forward. That additional dollars will start on 7/1/25 when we're able to start billing. Part of what we get and the responsibility on the state is these providers have but pretty rigid certification that they have to meet. We have to provide some pretty intense oversight. We'll be collecting a lot of outcomes and data and information so that we can really do a better analysis of, are we getting what we need from certified community behavioral health clinics. The types of services, they're required to provide some very specific services: screening, assessment, diagnosis, outpatient mental health and substance use disorder treatment, crisis services, person-centered and family-centered sort of treatment planning, primary care screening and monitoring, case management or care coordination, psychiatric rehabilitation services, peer support and recovery support services, services provided by individuals who've been there. They've got the lived experience. And then community care for, have some focus groups, older adults, children, and our veterans and military members and their families. Right now, in being ready to go at pushing that one forward, we have 10 providers in the state that will be ready to go 7/1/25. And it's covering about 64 counties. So, being in all, we don't have every county covered yet, but we will. We'll be putting a process together in our plan of how we will have the state covered. We're in a demonstration project, right? So we got to do some of the federal requirements to be able to roll in more providers. But this is just one example. So as our system moves forward and we're able to track data, track outcomes, get local needs assessments completely focused upon behavioral health, we're going to be able to do more planning and kind of really deploy the right resources. If there's a noted area in the state that has super high workforce issues, we're going to target more dollars there for some creative strategies to increase that workforce and increase the quality of that workforce. That's just one example, but that CQI will help us continue to deploy new strategies.
Very good. Leslie, if you don't mind, it looked like from your body language, you liked a lot of what you heard there. And I think I even saw a thumbs up for the Medicaid project.
Yeah.
Talk a little bit about that, if you would.
You bet. I've been very supportive of that effort and did a lot of advocacy at the federal level with the appropriate agencies and legislators to try to help support Iowa getting that demonstration state status. It's a huge help to be able to have this happen. One of the biggest aspects I'm really excited about is that data collection because it brings in both accountability, but the ability to actually critically analyze what's occurring and what's not, and then build in those system gaps. I'm also excited because it will provide increased revenue to the providers. Our providers in the state of Iowa are really under reimbursed. We've demonstrated the ability to get Medicaid rates reviewed. But most of these are the nonprofit agencies who really rely on reimbursement, and we need to continue to increase our funding of these people that are doing this extremely difficult and important work. So I'm massively supportive of building out the CCBHCs because it's one part of that whole continuum of care that we have to improve and build upon.
Very good. Before we move on to the next question, Jess, I wanted to give you a chance. I don't know if you had anything to add on this.
No, I think just kind of second that in regards to the accountability piece and the outcomes. As a youth serving provider, I think that there are some just things that we're kind of going to be monitoring. I'm not sure that we've got everything kind of outlined for services that youth or their families would need. And so just really trying to see what would that look like and if there's ongoing gaps in care, or just making sure that there is that accountability to good outcomes and that there's people monitoring that and it's tied to the funding moving forward.
All right. Let's get to another question from one of our viewers here. And again, as a reminder, if you missed this earlier, at any time, if you'd like to ask a question of our expert panel here, put that in the chat and they'll feed those to me and we'll get to them as time allows. Another one here, and forgive me, there's another acronym I'm not familiar with. So first of all, please someone tell me what this acronym means. The question says, my organization wants to look into AOT and find out what more information on what that would take to implement. Where could you direct us to get that information? What is AOT and where do they get that info?
Sure. So AOT is assisted outpatient treatment. It's specifically a program that helps people with severe mental illnesses who don't know they're sick, so they're not adherent to treatment, and they've gone through the revolving doors of being repeatedly hospitalized or arrested. You can reach out to me. I'm at lcarpenter@iamentalhealth.com. You can also reach and go to the website for the Treatment Advocacy Center. Full disclosure, I also work for the Treatment Advocacy Center as their legislative advocacy manager. I'm the person that did all the work to get the first AOT program started. So I'm happy to talk with you and connect with you. But if you go to the tac.org website. You can find a huge amount of information in the area that's labeled AOT or assisted outpatient treatment.
All right, perfect. Thank you very much for that question. One of the main reasons for this latest reorganization was to create and this has been alluded to a couple times, was to create a balanced and equitable system of care across the state, meaning that no matter where in Iowa you live, you'll have access to, at the very least, a core set of services. Again, as part of this transition, the state is working to define those core services that'll be required everywhere. Another kind of update here question, Teresa, if you don't mind, what can you tell us about that process of defining core services? And is HHS confident it'll be able to establish that equitable care statewide? And as an example, when in our coverage of this new law and this transition, one Eastern Iowa leader expressed concern, and you mentioned the map and the new districts that the Cedar Rapids area district will be service rich because of the large population here, but that person also worried that maybe other districts with smaller populations might have trouble. So tell us a little bit about that, if you don't mind.
Sure. So behavioral health services, as we talk about, really is inclusive of everything from prevention, education, community engagement, treatment, crisis, and recovery services. We right now are working on our behavioral health state plan. We're working on our behavioral health administrative service organization contracts and our administrative rules. And a combination of those things will start to define what all of that is about. As far as being ready to go, well, and I'm also going to say on that, we're working on those things, but I want to be clear, we're not going to do it in a silo by ourselves. We're working on them. We're hoping to have end of the year, beginning of next year, some drafts so that we can get it out to stakeholders. And we've started some focus stakeholder conversations already as we're pulling things together. But we're going to get it out there for public comment and public input so that we can make packages that are promising what this legislation has set forth for us to do. So as far as being ready on 7/1/25, implementation's a process, not an event. It doesn't switch the light switch doesn't switch right away. Remember, we're going to have new administrative service organizations. We're going to have new staff. We're going to have old staff learning new processes and learning the new way of doing things. We're going to have our stakeholders sitting around the table with us, kind of learning our way of new things. So it'll be awkward at first, right? We're going to have some bumps. No doubt we will have some bumps. So that 7/1/25, our main focus right now is how do we take these systems that are either changing or ending, like the MHTS regions, and how do we make sure that we have continuity of care, that what people have been used to getting doesn't end for them, that we're able to move into the system, keep folks getting the service that they've been used to getting, their residential, their outpatient mental health, their substance use disorder treatment. Those things can remain for them and not be broken for them right away. So that's our main focus. We'll have some bumps, we'll have some awkwardness, we'll have some journey. We have a journey to go on here. We have continuous quality improvement to make sure we're going to get that data and see where we have gaps and see where we lack consistency. See where our navigation isn't working as strongly as we need it to do, and we're going to fix it then, right? That'll be all a part of the process of implementing a new system, and we'll continuously be doing that. So I think communication as we start is going to be so important. Our stakeholder communication, us reaching out, us connecting with those local advisory councils, even us as HHS having a presence with alongside our behavioral health districts.
All right, very good. Appreciate that. Before I move on, maybe just Leslie and or Jess, again, as we talk about those core services, is there anything, as you're watching that unfold that is important to you or your organizations?
You want to go, Jess?
Yeah, I think it's just, really being cognizant of what the system needs are and being agile to meet those needs. So getting those services implemented just statewide.
Yeah, and I'll just say, all of that is very important in terms of having all those types of services available everywhere across the state. We have huge challenges with the very rural areas in terms of having enough providers of different types. So I would like to see the state continue to invest in more building up the number of people that graduate as nurses, as mental health therapists, as psychologists, as psychiatrists. We've done some of that work. We added psychiatric residencies, but we need to be thinking about psychiatric nurse practitioners, psychiatric PAs. We need to be building out the workforce and paying them better to do the work that's needed.
Leslie, this is amazing because we have another question from a viewer that I think is like literally tailored to what you were just talking about. So let me ask that again, and maybe you can add that. So a viewer asked, my sister is a psychiatrist in CT and creating telehealth psych services focusing on the autistic community because of a dearth of mental health, a lack of mental health professionals here. And their question is, how do we empower other innovative entrepreneurs? Since it sounds like you were already starting to start talking about that, Leslie, do you have a thought on that question?
I do. I'm very grateful to the state for continuing to pay for mental health telehealth. First of all, that's been a huge help in terms of creating access in some of these rural areas. And it's used in a variety of ways that are really, really helpful. In a rural hospital ED that doesn't have a psychiatrist, they're able to go ahead and call up and get that consult, which is really helpful. And yes, we need providers to be thinking as creatively as they can in terms of how they can use technology. And we also need the payers to come alongside with that and pay for it with equal payment that they would pay for an orthopedic surgeon, that they would pay for cancer services, right? We need to continue to have the insurance companies pay for things just like they would if we had any other physical illness. It shouldn't be as difficult to get that payment out to the providers for providing the hands-on care. I also want to make the point that we also need to be doing more training, especially de-escalation training for people that are working in hospital EDs, in psychiatric units, in group homes. My son's in an IRSH, but there are some staff that have no idea about what's involved with helping somebody with a severe mental illness. And we need to consider them to be some of the most important workers across the state and provide them with the training so that they can feel empowered and able to do their job with skill and compassion.
Good. Teresa, and forgive me, I don't know if this is necessarily in HHS's wheelhouse, but as far as providers and in especially in mental health professionals, is there anything in the HHS's sphere that is trying to address that?
Yeah, I think especially when, Leslie got me, really thinking about the quality of the provider and the resources for the provider to build their staff up and the support. I know, Leslie mentioned IRSH, which is intensive residential service homes, which is one of the other initiatives when we had a work group that gave a lot of legislative recommendations of some additional services. And that's one of them, to try to address really those really complex service needs that some of our individuals are faced with. And one of the things with the IRSH that is supposed to be there is that clinical support for the staff. When you think about staff need to feel money's not the only thing in a job. They need to feel confident and safe in the work that they're doing, and having the supports in place for them, as well as that education and that training and that understanding of what their job is, what they may be faced with, what situations that they may be faced with and have to manage and deal with. So I think we do have a role, and we do provider certification and licensure, and we do have a role of having those rules built in such a way that we are having expectations of provider organizations that they have to do that, and folks do need that.
Very good. Jess, did you have anything to add to this before we move on?
No, I think it's all duly noted, and it's just more about not just like the parity and how they fund, but there's so many things from parity across the insurance providers of the same requirements for documentation, shared information. Like there's so much that we could do, I think, to help streamline things across the continuum.
Yeah. All right. Jess, we'll start with you on this next one. But I'm curious to hear from both you and Leslie on this. I think this one is a little more out of Teresa's hands as we start to talk about funding, which is, of course, is always a critical component in this kind of discussion. I know advocates have stressed the need for higher Medicaid reimbursement rates is one example of, and that's something that's determined by lawmakers. Jess, again, starting with you, would a boost therapy the best way to help sustain and strengthen these programs, or where else is the funding needed, and how critical a need is that?
Yeah, obviously, increase in rates always does help when you talk about kind of fee-for-service providers here. I think the regular rate increases would help. There's many times in the last advocacy efforts of its identifying services that haven't had a regular rate increase. But I think it goes beyond that. I think a lot of providers across the state are really struggling with workforce. So I think the state could really do more to help create some workforce retention and strategies just to keep Iowans here, whether it is additional training programs or incentives to get more providers in the field, because we have lost a lot of providers, which does pose significant challenges. We kind of talked a little bit about the increase in acuity needs. And so just an support, I guess, to meet those higher needs. A lot of the providers across the state that I've heard from, their facilities just don't provide the safety and security measures that are needed. So it's not just training, but it's also really making sure that providers have the resources readily available to them in order to provide those services, keep their staff safe, keep those individuals that need care. Also really looking at how do we boost our infrastructure, providing access to rural communities. I mean, that is a critical piece, but a lot of the rural communities don't have the infrastructure to support telehealth either. And so really looking at how do we really look at those zones across the state that might be just not readily available. Also shared data knowledge, how do we ensure that information flows with the individual receiving care and not have to have them continue to fill out additional information as they go through that continuum. So I think there's a lot that we can do that's beyond just fee-for-service rate increases and really improve care here across the state.
Excellent. Leslie, give me your thoughts if you would.
Yeah, I agree with everything that Jess just said. And I would add to it that, we have seen state investment in mental health services. We're grateful for that. I'm extremely grateful to the leadership at HHS for all of the intensive hard work they're doing. This is a lot. It's a lot going on all at once. Some of the funding solution actually comes from the federal government. We need to end what's known as the IMD exclusion, which is the Institutes for Mental Disease exclusion. It's part of the Medicaid Act of 1965. And what it does is it limits federal matching Medicaid dollars for any facility with more than 16 beds. And a lot of us realize that led to the massive deinstitutionalization. But it also limits the number of beds at our crisis centers and our residential treatment facilities at all parts of the continuum. So there's an act at the federal legislature called the Michelle Alyssa Go Act that's to change that bed limit from 16 to 36. It's a bed that we are actively working to try to get passed. I highly recommend anybody that's interested in this, write to Charles Grassley, write to your representatives at the federal level and encourage them to sign on to that bill. Sorry for being an advocate, but it's what I do. But some of it is the federal investment because the providers of all sorts of health services in the state of Iowa are paid a lot less than people that are providing these services in Illinois and New York. Iowa's really under reimbursed from the federal programming as well. So some of the advocacy is state level and some is federal. And, the more voices we can get into the work, the better.
All right, appreciate that. We're winding down our time here, folks. Want to start to close it out here, but to our viewers, again, thank you for joining us. And if you do have any more questions left, now would be the last chance to sneak one in, and we'll see if we can get to it. But I wanted to really quick touch on just something that you brought up there, which is workforce. And I mean, as any of us knows, that's an issue that is affecting literally every sector and industry out there, sounds like no different here. And I assume, Jess, you're talking about not just like the physicians, the providers. You beyond that. Could you just expand on that? And this is such a important talk, like I said, for everyone out there. What are the workforce issues you all are facing?
Yeah, I think it's at every level that we're really seeing a need, whether it is direct care staff and residential units to licensed therapists. Really just needing to try to identify strategies to get them in the field. So whether it's certification programs or accelerated programs at the college level, just really trying to think creatively about how we get providers in the field and incentives maybe to keep them working in the area.
Leslie, are you seeing the same thing?
Absolutely. We need more of everybody. And we also need to acknowledge their hard work. I'd love to see an award program. I'd love to see a free continuing ed that's paid for by the state. There's so many things we can do to acknowledge and reward them for the hard work that we're doing. There's opportunities there. And again, the expansion of the professional program, let's fund more nurses. Let's fund more therapists. Let's fund more physicians. That's stuff that we can be doing that will pay off over time, building up our pipeline.
All right, very good. Before we leave, I want to give all three of you a chance to just give any closing thoughts that you have, anything maybe that we didn't cover, or just to kind of put a button on this. And again, as you all form those thoughts, I'll remind our viewers that we do have a couple minutes left to maybe sneak in one more question if anyone has one. But aside from that, Teresa Armstrong with HHS, I'll have you start us off here on any closing thoughts you have to put a button on our discussion here today.
Sure. I guess I would say, thank you for the opportunity today, and just thank you to the people here today, and Leslie and Jess representing advocacy and providers. I can't stress enough that this is a collaboration, and we all have a shared responsibility. And HHS has a commitment to being as transparent as we can in the development and implementation of the new behavioral health system. And we can't do it alone, right? We can't do it by ourselves. And you've just got our commitment that we are going to do this together. Some patience and understanding. There's going to be some hiccups, but we want to address those, right? And we want to tackle them. So again, just thank you.
Very good, Leslie Carpenter. Give us your closing thoughts?
I'd also like to thank you for the opportunity to talk about this. Obviously, I was glad to, because it's a chance to help educate more folks about the needs of people with severe mental illness. So I'm grateful for that. And I am grateful to all the providers out there and the legislators and HHS for all the work everybody's trying to do to make the system better. It is work. It took me 5 years to get the first AOT program off the ground. I understand the complexities of what's going on currently in the state, and I'm appreciative of the hard work of everybody that's working to make it better. So thank you.
Very good. And Jess Kelly, finish us off here with your closing thoughts.
Yes, thank you for having me today as well. I think it's that recognition, not one thing is going to fix the system. We didn't get here overnight, and it's not going to resolve overnight. So I do think that there does require that patience, the ongoing advocacy, and just the recognition that it is going to take time and that multifaceted approach. So really that focus on outcomes and ensuring that there is quality care here. So excited to kind of see where we go here.
All right, excellent. Well, let me take my turn and thank you all for being here to have this discussion. We can't do it this kind of thing without folks like you all who are so invested in this and have your varied perspectives. This was exactly the kind of discussion I was hoping for. I really appreciate the panelists who joined us to provide their expertise and insight. And then also, again, thanks to our track sponsor, Taninger, Jess's organization there. And thank you to everyone who tuned in. Thank you all for listening and joining us. As we go out, please be sure to check out the conferences full schedule at iowaideas.com and see if you can find some more great sessions just like this one that you might be interested in listening into. And if you miss them, all of the sessions are being recorded and they'll eventually be posted on the website, and you can watch them there. So make sure you check that out as well. So I think that can wrap us up here. Again, on behalf of our guests, Leslie, Teresa, Jess, thank you so much for being here. Thank you, everyone, for listening. Thank you, and have a great day.